Mangino is Professor Emeritus at The Ohio State University and the Wexner Medical Center, the Division of Infectious Disease. Her career focus and research interests have been on the prevention and control of healthcare-associated infections. She was the medical director of clinical epidemiology as the hospital epidemiologist and was a member of the antimicrobial stewardship team for 20 years. She's quite an expert in this subject. She has over 70 publications, and she received her MD from the State University of New York, Downstate Medical Center in Brooklyn, New York. She completed an internal medicine residency and infectious diseases fellowship at the University of Alabama in Birmingham. She received the Ohio State University Department of Internal Medicine Earl Metz Award in April of 2017 and has been in the Best Doctors in America every year since 2005. Please welcome Dr. Julie Mangino.
Thank you so much for having me, and thank you for that introduction, Joanne. So I'm going to just tell you a little bit about my somewhat circuitous route to do what I'm doing today. So I grew up in Staten Island, New York, and I always loved food, and I had two younger brothers that were always hungry, and I liked to cook. So I helped my mom prepare meals quite frequently, and that's when I got interested in food. And when I was in high school, I was like, I don't know what I want to be. I guess I want to be a teacher because that's what everybody else did. And then I realized that there was a career in dietetics or nutrition. So the reason I chose SUNY Oneonta for my college was because they had a really good, strong program in nutrition and dietetics. And there were only one other program, that of Cornell University and Plattsburgh. And Plattsburgh was wicked far away from Staten Island. So I went to SUNY Oneonta and I studied foods and nutrition. And one of my most favorite classes actually was cultural foods, because I learned about foods from all over the country. And after I finished my college, well, during my senior year, I applied for a dietetic internship. And this person who really grew up within the confines of the Hudson and East River applied to the Brigham in Boston and Barnes Jewish in St. Louis. And I matched, you were only allowed to apply to two, and I matched at Barnes Jewish in St. Louis. And that was really where I was badgered with my New York accent, badgered out of talking over coffee and those kinds of things. So I completed that for a year, and then I realized that I wanted to get my master's in nutrition, but there wasn't a program in St. Louis. So in 1978, I moved to Boston and I started on my master's in nutrition. And there was sort of this epiphany the day that John Lennon was murdered at the Dakota. I was typing a 25-page paper on vitamin C, and I was so bored. I was like, you know what? I am never going to be able to complete this master's. This is so boring. Okay, I learned all about too much vitamin C and kidney stones, too little vitamin C and scurvy. And I was like, there's got to be more. So, as a dietitian at Mass General, where I was working after I left Barnes Jewish, I was working in the critical care units and the burn units. So, oddly enough, very few of my patients ate food. They were on total parenteral nutrition with big catheters in their necks, or they were on tube feedings. So I really realized that this was way more interesting than just the food. So I took care of some of the early patients with toxic shock syndrome, Clostridium botulinum poisoning from the Vichyssoise French soup. And I went to my professor and said, I can't really do this anymore. Well, what do you want to do? And I said, well, I think I want to go to medical school. Oh, no, you don't want to do that. I'm like, I think I do. Please take a few more courses. So I did that and then started looking into all of what I needed to do to apply to medical school. And I was living in Boston and had access to Boston University, Harvard University, Boston College. So I was able to complete all of my pre-med courses at a variety of Boston colleges to be able to sit for the MCATs. And I did that in 1984. And stupidly, very stupidly, I did that while I was still in physics. So on a very sad day in October of 1984, I got my scores and I did really crappy in physics. Like I think 15 is the best, and I think I got a 3. And I realized that was really, I was feeling like I just, I wanted to sit for the test and do well, supposedly, but really and truly it was stupid of me. So I finished physics, and in January I took a Stanley Kaplan course, and I really focused on everything that I needed to do for the test. Because my grades in the schools that I was going to for physics, calculus, inorganic, organic, bio, they were all, B's and A's. And so I sat for the MCATs and I did very well. And in November, I actually withdrew my application from many, many programs because of my crappy score. And then I left about, 6. And I was very lucky that I was able to get into SUNY Downstate. It was one of the schools among about 4 others that I didn't withdraw my application from. Realized I was 7 years older than all of my compatriots. But anyway, I went to school at SUNY Downstate, which was in Brooklyn, and I'd actually almost never been to Brooklyn, despite the fact that I lived on Staten Island, and I trained in a very rough neighborhood. I mean, there were drug deals going on every night outside of the hospital. The Knife and Gun Club met Monday through Sunday. So when I first started on the trauma service, I stupidly called my mom and said, this guy tells me that he was just walking down the street and he was shot at. I said, I am so lucky. I don't have any friends that have been shot. And my mother was just like, what is wrong with you? Do you understand? these people were not exactly, you know, your friends. They're dealing with different things. That's why you're seeing all this violence. And it was really it was very hard for me to see so much violence every time when I was on the trauma service. But I still learned a lot. And then I guess I took care of some really sick patients with infections. I took care of a lot of AIDS patients. And I realized that when you went into infectious diseases, you made them better immediately. So with cancer medicine, you have to make somebody worse first, and then they get better. And so I really enjoyed that part. And when I was a dietitian, I had also worked in the burn unit, and I had seen a princess from Spain med-flighted to Mass General, and her bandages were all yellow from this dye that Pseudomonas, which is a bacteria, produces. And I was fascinated by that. So I moved south and did my internship actually at the Medical College of Virginia in Richmond. And it was the first hospital in the nation with computer order entry. And it was very painful for me. 45 minutes to, you know, plug in everything. And 5 other people besides myself left the program, and I went to the University of Alabama, and I finished my residency, and then, and I loved every minute of it. I was a Yankee, and there were very few women in the internal medicine program there, and in fact, I was the second female fellow in infectious diseases in the history of the program. But I had a fantastic education, and I came to Columbus, Ohio in 1995, and I came in as an assistant professor, and there were some issues with water issues in a bone marrow transplant unit, and I got very interested in trying to solve that problem. And it was a non-tuberculous mycobacteria that was in the water, and I figured that out. And soon thereafter, I became the hospital epidemiologist. And I worked to increase compliance with hand hygiene, with prevention of catheter-associated bloodstream infections, ventilator-associated pneumonias, urinary tract infections with catheters, we call them CAUTIs, and surgical site infections, and healthcare-associated C. difficile. So I had to interface with a lot of surgeons and administrators along the way. Doing that really was one of the most rewarding aspects of my career, in addition to teaching medical students and teaching residents and teaching infectious diseases fellows. So I think that it was really a fantastic career. And although I retired in 2018, February, I had full intention of coming back. And I teach a clinic a week. I teach 3 first-year ID fellows and 3 second-year infectious diseases fellows. You know, once a week I have one of those 2 groups of fellows, and then I see patients with them. And it's still extremely rewarding. And so I've loved my retirement. I love to garden. I used to love to travel. and I hopefully will again. And so what am I doing now? So I am working on a new N95 mask that is all US made, that is 100% reusable. I'm working with a company in California, and it's going through the appropriate steps because people around the country are still getting only one N95 mask a day to take care of patients with COVID, and sometimes they have to use that mask for 5 days. And although the Ohio State University has done fairly well with not having healthcare workers get infected, I think there are a lot of other people, even outside of healthcare, that can potentially benefit from this mask. And it's hopefully going to be very cheap, $2. And that's one of the projects that I'm working on. I'm also working on dental stewardship. So I did a project with one of the pharmacists and with the CDC and the orthopedic surgeons about getting the orthopedic surgeons and the dentist in the same room, because the orthopedic surgeons want patients who may get their teeth cleaned twice a year to take antibiotics for the rest of their life after they get a joint placed. And the truth of the matter is, there's really no good evidence for that. And when you think about the number of antimicrobial prescriptions for every person who's had a knee or a hip replacement ad infinitum, that adds up to a lot of antibiotics. So I'll be working with, so we did this project in June of 18, a few months after I retired, and we recently got a grant to work with about 10 practices here in Columbus, Ohio. So that's something else that I'm working on as well. And lastly, although I'm not taking care of patients in the hospital with COVID, I've tried to stay up to date on all of COVID for my own personal self, and because, of course, anybody and everybody has a lot of questions about what to do. So that's me, and I think if you have any questions that you would like to ask me, I'd be more than happy to answer them, but I also must say, if I don't know it, I have a pad of paper and I can look things up and hopefully get you the right answers.
Great, I appreciate it. Charlie, go ahead. You're muted though, Charlie.
Is that better? You had mentioned that you got kidded about your New York accent. My wife grew up in Brooklyn and New Jersey. I grew up in Richmond, Virginia. And when we first came to Columbus, we were in a restaurant and asked for glasses of water. And the waitress said, "What?" I said, "Water." She said, "What?" About the fifth time, it was like a light bulb went out. And she said, "Oh, you mean cold water." So ever since then, I asked for cold water, never have had a problem.
Yeah, it was really beat out of me. I mean, every time I opened my mouth, they literally would laugh at me right to my face. There was no holding back.
Scan. So, Doc, I'm looking for other questions. Why don't you talk to us about, though, your take on COVID and the whole, what's the state done well? What have we not done well? You don't have to point to certain people or individuals. Just in general, what are we doing well? What could we do better as individuals and as communities?
So I think Dr. Amy Acton did a fantastic job. I think she really steered the governor to do the right things with closing. For example, I emailed friends at the health department for about 3 weeks before the Arnold happened, that we shouldn't have the Arnold, as I was, seeing how many people would come to Columbus. That was a fantastic step in the right direction for Columbus specifically. I think that the shutdown, as painful as it is for all of us, was the right thing. I think that we could have opened better. I think that, this is my personal opinion, I think that I'll leave it there. I think that another good thing was a few months sort of when the cases started going back up again, implementing masks in certain counties for high cases. To me, I think the mask mandate, in my opinion, could have been statewide earlier. And I think it would have sent a more unified message that we really are all in this together, as opposed to saying we're all in this together. So I will just tell you personally, it is challenging. We have hardly entertained more than 2 people at a time, never indoors. And so looking forward to October, November, and December, I think these are going to be doleful times. I think that it's wonderful that there are going to be so many vaccine opportunities within Columbus, Ohio. And I've already signed up, but I haven't heard from anybody as yet. And I think that will be an important step to ultimately lead to opening up again in 2021 or so.
Great. So I saw Mark Lamont and then Luke.
Yeah, thanks, Jeff. What is your realistic assessment of when we might see a vaccine that can be widely distributed?
My guess would be February. And why is that? I mean, the trials are all pretty much just starting. And I think that the different locations where the vaccines are being trialed are going to be exceedingly important in determining the efficacy of the vaccines, right? Because if I get, like the AstraZeneca is 2 persons out of 3 will get the active agent and 1 will get the placebo. But if I continue to be as careful as I am. I mean, I wear the mask and face shield when I see patients once a week, and I wear the mask everywhere I am, only entertain outside. I'm just not certain if you're going to be able to know the efficacy unless somehow I have a breach. Do you see what I'm saying? So that's my guess. You know, I'm a fan of Mike Osterholm and Tony Fauci because I think they have been quite practical. And I think it's never good to overpromise and underdeliver. So if we have it in December after Christmas, bonanza.
Luke? Nope, you're good. Scott Whitlock?
If there's no good evidence for the requirement of antibiotics in connection with dental procedures after a joint replacement, where did that requirement come from?
Good question. So that came from the orthopedic surgeons who felt that particularly in the Surgical Infection Society, the Orthopedic Surgical Infection Society, that modeling what we do for a patient with a new heart valve should be the same thing as for a new joint. And that was the thinking. So a lot of the evidence is not there. And the most common pathogens that lead to joint infections are bugs that come from the skin, like staph, etc. The oral flora, which is a plethora of things in your mouth, it's really important to understand having good oral hygiene, brushing your teeth twice a day, and doing the right things with flossing is probably as risky as getting your teeth cleaned. However, I think it's really important to understand that if you do not do those basic things that your mother, screamed at you about when you were a kid, there are a lot of problems in people's mouths that go unattended due to, no, they don't keep their appointments, or they don't have insurance, or they don't have this, or they don't have that. So that's a risk. And having looked in a lot of mouths over these 25 years, it's shocking.
Hey, Callaway.
Thank you, President Chip. Julie, you referenced the mask that you're working on, and my understanding is N95 masks really only effective if they're fitted to an individual's individual face contour size. So is that true? And how are you going to address that with the mask you're working on?
So that is exactly true. N95s, which prevent 95% of the particulate matter from coming in, are required to have fit tests whereby you are attempting to inhale something sweet or salty and see, does it come through or does it not? Is the seal very, very tight? So the mask that we're working on has an inordinately tight seal and has been fit tested by about 150 people, healthcare workers primarily, along this journey over these last 3 or 4 months. And oddly enough, it's only one size. And I would say one size has fit all but 148 of 150 people. The seal is inordinately tight. Will they need to be fit tested? If in a hospital, absolutely. They must pass fit testing. So part of what we're going to do is also work on an alternative size than the one size that we have that fits most.
Any other questions for the doctor?
How soon do you expect to have those masks available?
So I am hoping for the next 4 to 6 weeks. So they were tested at the Coast Guard lab for greater than 95% efficacy. We've had a couple of calls with NIOSH / CDC. The last one was August 7th. We have our patent applications into the FDA. And we are now, let me put it this way, it passed with a disposable 3M Honeywell filter. What we want is to create the first mask with reusable filters. And that is at a lab in California. And based on my recommendations with immersing them in 1 to 10 bleach so that you can clean not only the shell, the filter and the straps, the shell, the filter, the shell, the straps, and this filter, to make sure that whatever cleaning modality we use for it does not impede the 95% filtration efficacy. So those studies are going on right now at another lab in California.
Are N95 masks needed right now in the Western United States for the problems that exist? Terrible air quality.
Right, the fires. So I've been in conversation with Marcus, who's the engineer working on the masks as well. They're not in massive production. We've just gotten a company in Wisconsin to produce them, but I totally agree with you, and that is inordinately important because of the air quality being so horrible. I just saw in the news this morning.
Callaway, you got another question for the doc?
Yes, in terms of the vaccine, the flu vaccine is usually 1/3 to 2/3 efficacy, and only about 60% of the population takes it. Do you think the coronavirus vaccine will have a higher effectiveness and efficacy? And do you think we'll have a higher participation by our population?
So the issues with respect to the efficacy of the current flu shots are related to the changing strains that, the Southern Hemisphere has it first, which, by the way, for our summer, their winter, apparently it was quite mild as far as things. So one of my thoughts is perhaps, and I'll get back to the vaccine question, perhaps all the mitigation efforts we're doing for coronavirus with masking, hand hygiene, et cetera, is actually going to help decrease the risk of cross-transmission of influenza. So back on the vaccine. So the vaccine at its best is about 60% efficacious because We don't always get, now we have 4 strains, 2As and 2. We don't get the strains correct in the vaccine. That's one problem that leads to the max of about 60% efficacy. The other problem is that the uptake, it's improving, but it is not where it needs to be. And that's a serious issue because unfortunately, even with the 40 to 60% efficacy, that's the best thing we have at this, time for influenza.
Hey, Dave Pritchard, got a question?
Yes, I'll read my question. Can we trust the CDC direction that a vaccine is safe if the current administration is still in control when it comes out?
I'm going to give David Pritchard a quick response since she dropped off. About 12 of the CEOs of the top pharmaceutical companies signed a pledge. They published that in the Wall Street Journal last week. They are not going to change any of their extreme protocol for 3 human trials and double blind testing, irrespective of who's in the administration.
Okay.
We will see. All right, well, if the doc comes back on, looks like there's a couple more questions, Tony Fiore and maybe one other. So, all right, well, I just want to thank everybody for joining us today. Please spread the word and let members, friends, others know they're welcome to join us each week at noon. Next week, we'll hear from Jim Bruner, the PAST Foundation, why mentorship is the next horizon in education, how mentorship and learning can be used to help people. Everyone have a great week, and we are adjourned.